Thank you. So nice of you, Dr. Rupal, Dr. Chitra, Dr. Rajesh, Gaurav, and KP for staying with me. So I think what KP and me planned was that in this national symposium, let us bring out for the general audience the two basic concepts of smile and phakic IOLs. So I do not have any financial interest, and we all know the spectrum of refractive surgery has been shifting between cornea-based, lenticular-based, and for extreme of myopia, where we combine both the worlds and we do bioptics. So lenticular based, we all know clear lens extraction and phakic IOLs has been the two gamuts that we are playing. A wonderful paper by Jose came out with this historical overview of the various phakic intraocular lenses available in the world market. We all were playing in all these 20 years of our practices with the angle supported lenses, the Kalman Diode and the Acrisoft. Then came in the iris claw lenses, the Artisan and the Artiflex. And what made us feel good were these posterior chamber lenses, the ICL and the PRL. So the basic concept of these posterior chamber lenses, what made them popular and what made them safe was less damaging to the iris and to the endothelium. So the distance from the endothelium, excellent cosmesis, close to the nodal point of the eye, helping in gaining in the retinal size images, and the wow factor from the patient because of this retinal size image magnification, greater effective optical zone, and hence came off the night issues, and the sulcus location. So the stable location, reversible procedure away from the endothelium, and no damage to the specular count remaining stable, and very iris friendly. So that is what made these. Am I audible?
Yes.
Yeah, so that is what made these phakic intraocular lenses, the posterior chamber, very popular. So the companies manufacturing the ICL we've all been using from the start, and then came in the Indian companies, the IOC and the biotech, what they called as the IPCL. So the pre-op assessment, the patient selection, and the lens calculation are the three basic tools for the right direction of the surgery. Who is the right candidate? A clear cornea, a patient more than 19. But in my practice, I've shifted to almost 21 years, because what I believe is most of these ICL patients are either LASIK rejects or patients who are high myopes. So these usually show some amount of progression. So I have shifted my basic nomogram from 19 to 21 whenever I am attempting an ICL. No systemic illness, looking for connective tissue disorders, ruling out diabetes, a very stable refractive error, fundus pathology. All these patients, we have a routine, a macular examination, and OCT, because commonly we find CNVMs, hidden occult CNVMs, since these patients are high myopes, and a good peripheral indirect workup where you are trying to see even if there is any retinal degeneration. And yes, intraocular pressures with high myopes could be a concern, so a careful watching for intraocular pressures. A good preoperative assessment, anterior chamber depth more than 2.8, and specifically this has to be from the endothelium. That is what I talked for the beginners. The angles open grade, grade 3 and grade 4. And yes, no previous ophthalmic surgery, especially corneal refractive surgery, though this is now an indication, and no previous ocular pathology like keratoconus, glaucoma. Keratoconus now is a relative or maybe one of the indications where we are using post-keratoconus, these patients cross-linking, Fuchs dystrophy, low endothelial cell counting, or any other corneal pathology. Off-label indications that we've started now doing is penetrating keratoplasty, post-DALC, ICR, corneal cross-linking in children and in unilateral amblyopic patients, and yes, pseudophakia, where we are doing these piggyback lenses. There are certain contraindications which we all need to take care: pre-existing glaucomas, history of cataract, uveitis, or any other ocular pathology that could be interfering with the visual acuity. Monocular patients could be a relative contraindications. Narrow angles, yes. Smaller anterior chamber depth, obviously 2.8 is the cutoff value. Zonular abnormalities, you always need to dilate these patients. Look very carefully for zonular subluxations, because high myope, again, you could have those hidden subluxation or zonular weakness, and unstable refraction and any disease of the cornea. So recommended ocular examination, it's almost similar to what we do for all our refractive practices. But the two most important things which are the deciding is the sizing, which determines the size, is the anterior chamber depth and the white to white. A lot of debate among different people, practitioners, and which is more accurate and what is the thumb rule. For me, anterior chamber depth on a pentacam and a white to white on a digital caliper, these two work best for me. But yes, anterior chamber depth endo can be evaluated with IOL master, op scans, and pentacam. White to white you can always do with a digital caliper or an IOL master or an op scan. Now, sulcus to sulcus, or what we call as STS, can be done on an UBM, which is said to be more accurate, and angle assessments, gonioscopy, and an OCT and a specular count. So this is what we are worried for, sizing, because this sizing ultimately determines what is the vault where the lens goes and rests inside the eye, and what distance it keeps from his wife, that is the lens. So that is the vault, what we call it. A wonderful paper which compares this. These are the results of the blend Altman analysis of the inter-device differences of the anterior chamber depth measurements using an IOL master and a pentacam, an IOL master and an op scan, and a pentacam and an op scan. So I think they all disagree to agree between 0.03 to 0.3 millimeters. White to white, yes, digital caliper is a thumb rule, and IOL master would always overshoot by 0.3 millimeters vis-a-vis a digital or an op scan, and IOL master 500 gives an error of 0.5 millimeters and a pentacam 0.3 millimeters. So I trust the digital caliper and always take a reading on any of these devices wherever there is a slight uncleared area, or wherever there is a slight arcus, or where you are not able to make out the exact limit of the limbus. So an ideal sized vault would be somewhere between 250 to 750 microns, and an undersized and an oversized ICL is what we don't really wish. But what actually determines the vault size in these implantable Collamer lenses? A lot of studies, but actually the preoperative anatomy and the lens parameters also have some roles to play, and there has been 34% of the vault variance wherever we are implanting these lenses. So that means there is something else despite the anterior chamber depth and the white to white. The sulcus to sulcus is a better predictor of the vault compared to the white to white. White to white is on an average 0.3 millimeter smaller than the angle to angle. The angle to angle measurements, the clear lens rise, the ICL size, the ICL power, and the age. All these 5 factors are the determinants of the actual vault once the ICL goes and fits inside the eye. So a quick word of the lens rise. So if you draw a horizontal line from angle to angle, and how much is the lens rising above? If the lens rise is less than 600 microns and the anterior chamber depth is greater than 3.2, there appears to be a very low risk of pigment dispersion or the touch. Now, this lens rise is one of the key factors which determines where the lens is going to sit and how much would be the vault size. Now, this is how once you have taken the measurements, refraction and everything sent to the company, and this is how they now look at the sizing. The size of the ICL from 12.1 to 13.7. Now, what is more important is to watch here. Now, between these ranges, between a range of white to white 10.7 to 11.4, and when you have an ACD of 2.8 and 3.1, now if you look at the extreme of cases, the lens shifts. If the white to white shifts from 11.14 to 11.15 to a 12.6 size, that means just a 0.01 millimeter change in the white to white would shift the lens size to one size up. Now, these are the gray areas which would end up in surprise between a low and a high vault. So, depending upon your experience, then you can become so smart that you can play in between whenever these are at the borders, the white to white and the anterior chamber depth values. We all know these ICLs are friendly. They are Collamer material. Collamer is basically a collagen copolymer and it's coated by a fibronectin layer, which keeps the inflammation away. This is what the Indian lenses look like, the IPCL, multiple holes, and even the biotech got these phakic lenses in their armamentarium, and they work equally well. A study from the Ramamurthy group also came up with these, the Indian lenses, the predictability and the post-operative results being comparable to the ICLs. A quick word on the post-operative vault. We all know 250 to 750 micron. A low vault can induce cataract, and a high vault can cause a secondary glaucoma, increase iris pigmentations, and the pupil dynamics go off. You can have halos, and the chances of resurgery increase. So what is the troubleshooting? This last slide is a very important slide where I have compiled this. When you have a high vault with a normal intraocular pressure, you can just observe. A high IOP, AC shallow, you can, in case of a non-toric ICL, you can just rotate the lens vertically. That means a non-toric lens, if it goes vertically, because we all know that the internal wide to wide or the internal angle to angle is much more than the horizontal. So if you have a high IOP and a shallow AC, you can flip it vertically and that can resolve the issue. If it is a toric lens, you need to exchange for one size lower. So I think this is one very important take home when you have a high vault in cases of non-toric lenses. But if you have a low vault, no peripheral touch, in cases of V lenses, you can observe. But if you have a peripheral touch and there is no cataract, you can still observe for V4C. If you have an early non-progressive opacities, you can still observe for V4C. But if the cataract is progressive, you need to explant and you need to exchange the lens with one size up. Implantable Collamer lenses, the complications, there have been this wonderful study published in the Journal of Refractive Surgery. I think the cataract and the the acute intraocular pressure were the two important complications reported with these phakic intraocular lenses. And most of these cataracts were reported within 1 year of their implantation. So the major causes of explantation of these phakic intraocular lenses, wonderful paper by George Alio, where he believed that in his case series, it was the cataract which was the major cause of the explantation of these phakic lenses. Endothelial cell loss, corneal decompensation, the dislocation of these lenses, high intraocular pressure, and the ovalization of the pupil, retinal detachment were to a certain extent other causes for the explantation of these lenses, but to a very, very meager percentage. So thank you so much for